People all over the world face disparities within the healthcare system every day. According to the World Health Organization, half of the world lacks access to essential health services, and 100 million are pushed into extreme poverty because of health expenses. These systemic problems are not only experienced in other countries, but here in America as well. So we decided to take a look into how healthcare disparities are experienced by our peers in the city of Boston, and what our future healthcare workers are doing about it.
Hi, my name is Sarah. I'm a sophomore at BU and I'm a neuroscience pre-med major. Currently, I work as a pharmacy technician. I volunteer at Mass General and I also do research at BU Med, and I'm also part of the Red Cross, and I volunteer as well at the Red Cross Club at BU.
I'm Lindsay. I'm a sophomore here at BU. I'm a health science major, probably pre-nurse in the future. That's currently my path. And I work at a trial at BMC in collaboration with BU Med School. So I'm working with patients who have limited English proficiency to no English proficiency at all. And so we're looking at better ways of improving their medical discharge. So I specifically work with only minority groups. So I work with Spanish and then Haitian, Creole, Cape Verdean, and Vietnamese populations.
So I work with, I think, both demographics of people who aren't able really to afford or low income, and then higher income communities. I mean, I think even in Boston and from the area that I'm from, you can be one side of Boston, there's people who can afford so much, have high incomes, and you can drive 10 minutes outside of Boston, there's people who are low income, below poverty line. So I do work with both demographics, and I do really see both sides to the story in terms of disparities in healthcare.
On a global scale, life expectancy experienced a decrease due to the COVID-19 pandemic. However, other countries have been able to bring their rates back up. America is still recovering from the hit, and we have to ask, why is it that America is still undergoing a lower life expectancy than other high-income countries like Japan or Italy? Could it be due to the disparities in our healthcare system? Life expectancy has increased steadily since the boom of the Industrial Revolution, but at a disproportionate rate for people of color. The life expectancy for Indigenous and Black people are 65.2 and 70.8 years respectively, while the life expectancy for white people is 76.4 as of 2021. As of the 2020 census, about 41% of the American population identifies as non-white. This means that in conjunction with low-income white Americans, the average American citizen is or has experienced the inequalities associated with our healthcare system. If life expectancy rates are much lower for minorities and impoverished people, America's current life expectancy matches that statistic because many Americans fall into one or both of those categories.
I'm originally from Colorado, and I think the demographic is definitely different, and so I personally have been grateful to have not faced any serious medical difficulties or struggles in that sense where I wasn't able to receive quality health care, but I've definitely seen that quite prevalently in BMC especially, because I know comparatively to other hospitals in the Boston area, BMC, I think it's the statistic is really high. I want to say it's 50 to 60% of people there make less than the patients make less than $20,000 a year.
I do have a physician mentor at BU Med, and he has talked about how a lot of the BMC, because BU Med and Boston Medical Center are connected, how oftentimes a lot of their emergency department is filled with homeless people because of how many people in that South End area are below income poverty. So I definitely have been talked to about it, but I don't think it's really drilled in our training per se. At Mass General, I wasn't really talked to about, disparities in healthcare. When people are getting medicines, it's very hard for them to afford it because their insurances won't cover their medicines, and so it's been very hard for patients, especially who are lower incomes, to get life-saving medicines that they need because their insurance won't cover it, or they just can't afford it.
Most people cannot afford to go to the hospital unless it is a dire emergency because the cost would be too high, even with insurance. But without a job that provides health insurance, Americans are required to pay the price of seeking medical care.
I work for CVS, and I think while they try, I don't think they see enough how different communities are impacted, because I think they're such a huge company that they don't have enough insight to how people can or cannot afford medicines. And even these big pharmaceutical companies, they're jacking up prices of medications when people need it. They need their life-saving medications and they can't get it. I think with Mass General, I also am joining a team called Community Caravans, where they are going into lower income communities in Boston and bringing the clinic to them. So I think they are trying to, or an effort to make things better, but I don't think that they've done enough yet. But I do think it is their responsibility to help lower income communities or these disparities in healthcare.
The majority of people experiencing these living conditions are people of color, so they are disproportionately affected in many ways, including their health, by factors outside of themselves.
When I was onboarded, I had to do trainings for specifically my research, but I also was doing trainings instructed by BMC that every employee at BMC must take to learn about. One of the big modules they have is about disparities and what they're doing, the current trials and such that they're doing to combat those. My boss told me that actually there's a much higher chance of a person who doesn't speak proficient English to be literally put in handcuffs at your bedside because they're deemed crazy or manic, and that's super common in the ED, in the emergency department, which is a crazy statistic to think about, is that just because you can't understand somebody, all of a sudden they're crazy, even though they have interpreter services and they have such. So maybe that could be another thing that could be a disparity that could be edited.
According to the National Institute of Health, research consistently has documented that the continued impacts of systematic oppression, bias, and unequal treatment of Black women, and it is no different when dealing with healthcare. Due to deep-rooted racial biases, Black women often aren't taken seriously because their pain is minimized. Black women are 3 to 4 times more likely to die while pregnant or during childbirth. They have an elevated prevalence rates of chronic conditions associated with higher risk of severe maternal morbidity and mortality. They found that if Black women gave birth at the same hospitals as white women, the rates of severe maternal morbidity would decrease by 47.7%. Experiences within the healthcare system are different for different people, often depending on their race or gender.
Even the other day, a patient asked me when I approached her, and we were having a conversation about enrolling her, she asked me if I was going to remove any of her organs or any of her body parts, and of course we're not, but that's just I think goes along with that distrust. She just had no idea even what this kind of research would entail, and so I assured her, of course, we would not be removing her organs or anything of the sort.
According to the Center for Disease Control and Prevention, racial and ethnic disparities are driven by social determinants of health as conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. There are 5 overall categories, which include economic stability, education access and quality, healthcare access and quality, neighborhood and built environments, and social and community contexts. These all contribute to health disparities and inequalities. Think of it like this. People who don't have access to grocery stores with healthy foods are less likely to have good nutrition. That raises their risk of health conditions like heart disease, diabetes, obesity, and even lowers life expectancy relative to people who have access to healthy foods.
BMC actually has a huge community garden, and I think they fund they produce a lot of food, tons of food for the community every year. And I feel that's one initiative that's come out that seems to have really helped a lot of families in South Boston.
Just promoting healthy choices won't eliminate these and other health disparities. Instead, public health organizations and their partners in sectors like education, transportation, and housing need to take action to improve the conditions in people's environments.
When I volunteer at Mass General, I see a lot of times patients come in and they don't know where they're going, what they're doing, they're given no information, and I have to try to help them, but I can't understand. And I feel a lack of interpreters, especially at the information desk at Mass General, because a lot of times with people who come in and they're asking questions in different languages, no one knows how to help them because of that.
A lot of them just don't understand a lot of what we tell them, especially in medical terminology. And so providing a medication calendar, for example, or an audio recording would really help with that. A lot of them ask is there a cost? like, I don't know if I can afford this, which there is no cost, but is there like a cost? Like, will you guys, like, a question I get a lot is just like distrust of the medical system. There could be like more clear directions about even like how to go places in general that are in like other languages, and that's just coming from like, because I'm not in like in a language trial, but I think like that could be really helpful. There's like a really famous instance of like a woman in Boston who really needed to go to the hospital, but I think she was having an asthma attack or something, but she couldn't find the entrance to the hospital, and she ended up passing away because she literally couldn't find the ER. So like, I feel like, and I forget what the policy is, but that there's like a specific policy in the state of Massachusetts that's like dedicated to providing like better signage, and I think that could be one thing, definitely. And I remember the first time that I was enrolling this one patient, and they couldn't, I asked them if they had any questions about the document, and they said that they actually couldn't read the document in the first place. And of course, like, we just went through and like I helped them go through each section and whatnot, but I think that's also a discrepancy that we don't really account for a lot, and I think BMC could definitely implement more resources for that, because especially in the world we live in now, and like the city of Boston has like a very high number of like educated people, and we go to like a private university with a lot of resources, and in order to get here we all had to learn how to read, and so I think we forget that there's a lot of people in the world that don't even have that privilege, and so I think that's something else that BMC could work towards or try to incorporate.
There are multiple interconnected factors that influence an individual's overall health, so it is necessary for policymakers to be aware of the communities that they serve and their needs. One way that communities can better be served is through higher education, by influencing those who will later be dealing with and making decisions regarding the health of another. This could be in policy, but it can also be in hospitals as well. Boston University medical students are being educated on these topics in hopes of being able to combat these issues on an individual level as well as on a systemic one.
It's really important for people in our generation to work in a diverse setting, and kind of be able to see those different disparities, because I was previously working at a hospital in Colorado, which is like a primarily white demographic, definitely people that are probably middle, like have a pretty solid income, a steady income, and I think the kinds of patients that I was seeing and taking care of were very, very different, and so I think it's definitely important for med students now to be able to see both.
With my like newer experience coming up with the community caravans, I feel like it'll really broaden my horizons on how severe this issue is. But with my past experiences of working with patients in the pharmacy or at the hospital, I think it really has opened my eyes to this huge issue in healthcare.
It's really just establishing a connection with your patient, and you know, I don't just walk in and introduce myself and like go into my pitch. They often have, you know, some stories or things that they want to talk about first, and I obviously can't give any like medical advice or anything, but to be sympathetic and like empathetic of what they are going through, I think is really important, and recognizing that it's really scary to be in the hospital, like regardless, and that like I can listen to whatever they have to tell me, and establishing a connection with them first initially really helps.